And so I'm going to be talking on this topic. You may feel it's a repetition, but repetition is very important, and because it is the key to learning. So let us look at the very hard facts about LPD. It occurs in 5 to 10% of patients. Unexplained infertility we know occurs in 15 to 20% of cases, and a large fraction of unexplained infertility is because of the luteal phase defect. Recurrent pregnancy loss occurs in 8 to 12% of pregnancies. 40% of the women who have an RPL, they do have a luteal phase defect. So in the talk today, we're going to talk about all these factors, and we're going to address each one of them one after the other. And the first and the most important is, what is the definition of LPD? LPD is inadequate endometrial maturation due to qualitative or quantitative disorder in the corpus luteal function. What would this mean practically to us? That there's an inadequate secretion of progesterone by the corpus luteum, and this also results in a decreased progesterone receptors within the endometrium. Both the factors lead on to a luteal phase defect. I always used to think that the luteal phase defect starts only in the secretory or the luteal phase, but actually does not. If you really look at this, it starts much before in the follicular phase. So if you have an inadequate FSH production, if you have abnormal gonadotrophin pulses, you land up with a defective follicogenesis. If the follicogenesis is not effective, then your estrogen levels are less, and if estrogen levels are less, then the priming of the endometrium is going to be poor. In the secretory phase also, hyperprolactinemia by itself is a cause of LPD. Otherwise, and whenever there is a poor mid-cycle LH surge, or there is an inadequate production of LH, the corpus luteum itself is defective. If the corpus luteum is defective, the inadequate progesterone secretions, again we are going to land up with a luteal phase defect. So it's both the follicular as well as the secretory phase, both of them result in an LPD. Now the question of diagnosis. Till now, after so many years also, I think we haven't reached a particular diagnosis which can be considered that is the most practical, simple and a diagnostic method. Practically, we say if the luteal phase is less than 12 days, it should be treated. BBT is out because it's not, it doesn't have a very good quality, or it cannot be reproducible. Mid-luteal progesterone of less than 10 nanogram per ml is considered to be abnormal. And in such cases, we do find that if it's less than 10, then the chances of a LPD is quite high. But still, it is said that random serum progesterone levels are not a valid clinical diagnostic tool to evaluate the luteal phase adequacy. Sonographic. Yes, there are certain pointers when we do an ultrasound. If you're really open to when we're doing an ultrasound, we can suspect an LPD. Like if you have a follicular rupture at less than 17 millimeters, it's a very poorly formed, ill-defined dominant follicle. Corpus luteum is absent. There's an unluteinized, unruptured follicle. There's a lutein cyst formation. And if you have a look at the endometrium, even 7 days post-ovulatory, it is not homogeneous. All these factors will let us to really suspect that maybe this particular patient has gotten LPD. Since we were students, we have known that endometrial biopsy is a gold standard, but it is imprecise, invasive, and it is not reproducible, and hence currently there is no reproducible, physiologically relevant and practically clinical standard to be able to diagnose LPD. Then treatment. Yes, of course, we can treat the hypothyroidism, hyperprolactinemia. If treated, the LPD can be improved. Otherwise, it's an empirical treatment of supplementing with progesterones, HCG, ovulation induction with CC or gonadotrophins. Here I would like to say that if you're giving ovulation and induction, this does not improve the LPD. It increases the chances of pregnancy by making multiple follicles, but by itself, it does not improve the LPD. That is why you need a luteal phase support when you are even giving an ovulation induction. The question now we need to answer is, who requires a luteal phase support? Wherever we are sure she has an LPD, unexplained infertility, recurrent pregnancy losses, any ART procedure, be it IUI, IVF or ICSI, advanced reproductive age, if she's more than 35, 40, then the chances of LPD is much higher. Hyperprolactinemia, all down-regulated cycles, PCOS, and even women who have had exercises, strenuous ones, or are underweight. In ART cycles, why do we need an luteal phase support? This is because we have a supraphysiological levels of estrogen which may induce premature luteolysis. Follicular phase down-regulation, it tends to impair the luteal phase LH release. Pure FSH protocols, they have less LH. Whenever we do an OPU, we are going to actually injure the granular cell. There's a disruption of these cells. Controlled ovarian hyperstimulation tends to accelerate the endometrial maturation, and if we need to overcome any LPD. That is why in all ART cycles, be it IUI, be it IVF, be it XC, we need to give them a luteal phase support. Then the question, which drug? So the luteal phase support can be divided upon where it acts. If you're talking of an endometrial support, it is progesterones and estrogen. If you're talking of agents which support the corpus luteum, it's HCG, GnRH analogs or LH, and now we have more newer drugs like sildenafil and aspirin, which also have been found to improve the vascular dilatation and thus improve the luteal phase support. But the most ideal drug is a micronized progesterone, and it's a drug of choice. How does it actually act? It supports the endometrial growth, and it does so by improving the blood flow, increasing the oxygen supply by increasing the nitrous oxide production. It tends to act by quietening the uterus, and because of its uterus relaxing action, there's a higher chance of implementation. And we all have had these particular talks on progesterones and all, where we know that immunologically it tends to increase the anti-inflammatory response. That's the T helper 2 response, and that is why the progesterones have a multiple action at all levels, and they are found to be the best drug to be given for a luteal phase support. The question then, we know progesterone is good. Should it be natural? Should it be synthetic? So over here again, the verdict is very clear. It has to be naturalized progesterone. Synthetic progesterone affects mood. It increases the HDL cholesterol. It has adverse effects on the pregnancy outcome. It causes fluid retention. Thus, the best drug to be given is a naturalized progesterone, and that too a micronized progesterone. But it increases the half-life of progesterone. It reduces the destruction in GI tract. It decreases the particle size, and it enhances the dissolution. So we have come practically to the point that we need to give luteal phase support. The luteal phase support has to be progesterone, which is the best drug to be given. It has to be natural progesterone, and that too it has to be a naturalized micronized progesterone. Now, which way to give? Oral, intramuscular or vaginal? Oral, I know many of us have been writing oral because that's what the patient demands. It's the compliance of the patient is very good. It's an easy route to be given, but the bioavailability is only 10%. It's not very effective. Extensive first pass liver metabolism, a lot of side effects like sedation and hypnosis. We do have another oral drug which is dydrogesterone. That too is utilized for a luteal phase support in a dose of 20 to 30 milligram, and that is also known to be an immunomodulator. The other dose, the method is intramuscular. This is an oil-based preparation, very reliable. We are very confident when we give it, we know it's going to work. We are not too sure patients going to keep it vaginally or take it orally. So it's the, I would say the IVF specialists or the gynecologists are very happy with the IM. But we need to realize that the patients don't like it much. It causes a lot of pain, it causes a lot of abscess formations, and that is why the patients are very unhappy taking IVF. And we know some of the patients have refused to go for another IVF because of all the injections that we have been giving to these patients. But the good thing is that once given, it tends to last for 72 hours. The third and the most common route and the most effective is the vaginal. It has a targeted organ delivery. It reaches straight the cervix as well as the endometrium within 4 hours of having given it. Very high concentrations, first uterine pass effect, minimal side effects because it doesn't have any liver absorption that takes place. If we are convinced that this is the right for the patient, no patient is going to refuse it, and once they start taking it, it's got a very good compliance with that. I would just like to show this particular of the various continents. What is the use, the way they have been using? So in the Asia, we have seen 52% want vaginal, 10% intramuscular, and about 27% of all the cycles are both combined vaginal and intramuscular. South America and Australia, 100% vaginal. They are not using intramuscular at all. North America, surprisingly, they are quite similar to what we are. 41% is vaginal, 30% intramuscular, and 20% they're using both vaginal as well as intramuscular. So if you really look at it across the world, all the continents we are talking, predominantly only vaginal is the route that has been most preferred and is being used. Now the progesterone preparations that are available, micronized, it's the oral, the vaginal gel, we have vaginal pessaries, the spray had also come once upon a time. Intramuscular we have, and we also have a subcutaneous which is an aqueous based intramuscular, and the oral that is a dydrogesterone to be given. When to start? This is something which is very controversial. In an IVF cycle, acceptable window is 24 to 48 hours after an oocyte retrieval. 1 day after ovulation, HCG is given. 1 day after oocyte retrieval, but definitely 100% on the day of an embryo transfer, it should be started. For an IUI, it's the same day or the next day. Once we have documented rupture, it can be started on the same day or the maximum by the next day. When to stop? again controversial. We all tend to have our own practices, but I think all of us are continuing up to 10 to 12 weeks. And now if you look at the various reports, it has been seen that all over, especially if you look at this particular presentation again of all the countries, predominantly, be it Asia, Europe, North America, South America, everyone is continuing up to 10 to 12 weeks. There are very few countries which are only giving up till pregnancy test positive or that the fetal heart has been seen. So we are not wrong if we are continuing up to 10 to 12 weeks of pregnancy. So this is the Cochrane review, which has said there's a significant effect in favor of progesterones. There's no evidence favoring which route or which duration for the administration of progesterone. HCG definitely should not be given because of the risk of OHSS is much higher. Addition of any other substance like estrogens or HCG did not seem to improve outcomes, and they too in the end made a conclusion that progesterone seems to be the best option for a luteal phase support. Now, when we are giving vaginal progesterones, do we need to do a serum progesterone level? This particular paper says no serum progesterone levels need to be done because the vaginal and the serum progesterone do not correlate at all. In the antac cycles, whenever we have given a GRH agonist, they say then we can use a modified luteal phase support where small doses of HCG or LH can be given along with the progesterones. So now I'll just come to evidence. I was given 112 slides by Sun Pharma full of evidences, and I went through all of them, but I realized the ones that I felt I need to share. So I'm just going to be sharing 4 evidences with each one of you. So first evidence is for an IUI cycle, vaginal or intramuscular progesterone for an LPS. So this study has 312 patients, 4 types. 2 were given IM progesterone 25/50, 2 were given vaginal progesterone 400 once a day or twice a day. They looked at the primary and the secondary outcome, and they found that in vaginal and the intramuscular, the rates were comparable for the ongoing pregnancy as well as the live birth rates. So there is no difference between vaginal and intramuscular, and they did conclude that vaginal progesterones are easy to use, convenient method, and they should be promoted more than IM progesterone unless and until you are sure your patient is not compliant and is unlikely to take the progesterones. Another study, again vaginal against an intramuscular, but in the ART cycles. So in the ART cycles, they compared the two, and they found that the vaginal progesterone, be it gel or 600 milligrams of progesterone, was comparable to 50 milligrams of intramuscular progesterone, which has been found to be given. And they also commented that whenever the vaginal progesterone was given, the miscarriage rate was slightly lower, though not significant in these cases. So vaginal route is preferred over IM injection, easier, less painful, less time consuming than an intramuscular, and hence it is the route that should be preferred. Now we come, what type of vaginal? Are we talking capsules or are we talking of gel? So this study has compared the two of them. 122 cases, they put 200 milligram 3 times a day, and 122 cases was 8% of vaginal gel was, and again they also concluded that the rates were exactly comparable between the progesterone capsules or we have been given to gel. There is no difference, it is not statistically significant. So we can use either of the two, they are found to be equally effective. And we all want to know about the dydrogesterone comparison to the vaginal progesterone. I could not get a direct study in the ART, but the study that I did get over here about the endometrium in phase. They found that when a vaginal progesterone was given, the in-phase biopsy of the endometrium was much higher as compared to the dydrogesterone, and thus they concluded that there was more synchronicity in the in-phase development of endometrium with vaginal progesterone as compared to a dydrogesterone. Now we also have, from the Sun Pharma itself, we have an aqua-based progesterone injection. So they tried to compare in the IVF cycle the use of this aqua-based injections as compared to vaginal progesterone. This study had 800 women for IVF cycles, and they had given aqueous progesterone 25 milligrams subcutaneously or vaginal progesterone 100 milligram BD daily. And if you look at it, the ongoing pregnancy rate is same. Whether it's clinical, intrauterine pregnancy, implantation, birth rate, take-home baby, everything was comparable between the aqueous as well as the vaginal progesterones. And they concluded that probably the subcutaneous aqueous progesterone can be used in people who tend to prefer not to use the vaginal progesterones or who wish to avoid the side effects of vaginal progesterone or the IM, that's oil-based injections. And the last studies that when they compared with the gel and the aqua-based progesterone, they found that the rates were exactly comparable. There was no difference in pregnancy rate, miscarriage rate, take-home baby rates. It was found to be same. So if we really look at all these studies, See, studies, it depends on what you're looking at. Right? There are plenty of studies in the market. You can really take out. But when I looked at all the studies that they're given, I felt that these are the ones which have told me very clearly that vaginal progesterone, if I have the confidence that this is the right way, it's much easier to use, the patient compliance is better, the pain, the abscess, everything is going to be much less. We need to use the right route and the right way, and then we are going to be getting the equal results. So we need to really actually overcome our fear, and that's the purpose of going through all this particular evidence. So I would like to just summarize in the end by saying that progesterone is very important for the luteal phase because it promotes the vasodilatation and uterine muscular quiescence, and we need to make the uterus quiet to have a better implantation to prevent any ectopic pregnancies. Progesterone also tends to increase the endometrial receptivity, and this particular change, it occurs when the endometrium is estrogen primed, and this increased endometrial receptivity is another reason that we want to decrease the failures of the IVF is concerned. So to conclude, abnormal luteal phase function is quite common. There's still no diagnostic test which is 100% to be able to diagnose it. In a cases of cycles which are unstimulated natural cycle, there's no role of giving luteal phase support. Luteal phase support is only to be given in the IUI, or we have the ART cycles, but an unstimulated normal cycle, there's no role of giving a luteal phase support. There's no difference in the different routes of administration. For an IUI, the CC stimulated cycles, although evidence says it doesn't support LPS, but as we had discussed previously, in these cycles also we require a luteal phase support. Vaginal progesterones at a dose of 200 to 400 milligrams from the day of IUI is good enough for these patients. For IVF, all patients need a luteal phase support. Vaginal progesterone is good enough, well efficacious, better tolerated than iron preparation. The date of start, as we have discussed, is little controversial, but definitely by the day of transfer it should have been started in this. HCG increases the risk of OHS, so should be very well evaluated, and then it needs to be considered to be given on to them. So I would like to end by this particular quote which says, it's not necessarily the amount of time you spend at practice that counts. How many times you sit in a clinic and write, that's not the thing that counts. It is what you put into your practice, that is what it counts. So we have been hearing this lecture again and again of the luteal phase support. Repetition is important because repetition makes us implement it so that next time a prescription comes, we know we are not in any doubt and we can just write it over there. Thank you so much.